So as I said, I'll give you a personal summary, then I'll tell you why I'm going to talk to you today about maximizing patient outputs. And I'm going to do that specifically on stroke because that's the research that I am about to do. And I'll tell you almost anything you need to know about stroke in order for you to understand and for me to understand as well what I'm going to do. So as a high review of myself, click. Okay, so I did a PhD in biomedical engineering where I tried to understand if we could improve upper limb prosthetics. And the way that I did that was I acquired signals from our forearm and I tried to see if we could detect when the thumb could rotate, because upper limb prosthetics are great, but their thumb don't rotate. And if you have a thumb, which I think we'll do, you know how important they are. So I used self-organizing feature maps as unsupervised machine learning, and I also did coherence analysis because just as Anna was saying, with EEG signals, EMG signals, which are the signals come from our muscles, they're very complicated. So you can do it in time and in frequency as well. I have experience in developing medical technology for which you first test what exists. In this case, the technology that I develop is a wrist hand orthotic, and I'm sure you've all seen wrist hand orthotics, the things that they don't work. So for these, the data-related method that I did is that I quantified why they didn't work. I produced evidence, and that led to a product design specification for a new device. Then I have had the great opportunity to work with people around the world where surveys were used to do a product design specification, or we're trying to understand abnormal movement to help people from lower income countries, or trying to create methods in which people that are from remote settings could actually access care. So that led to an award that I won in 2020, just before the pandemic hit, about understanding tetanus. Tetanus in here is not a thing because we have vaccines, but in countries like Vietnam, where they are competing against traditional medicine, vaccines are not greatly taken. So we were just trying to understand, or we were not, because it hasn't happened because of COVID. So we are trying to understand if we could give information to the clinician to know when to reduce the muscle relaxant from a muscle perspective. So I was trying to quantify and provide a tool to help them. And the reason why I'm here today is because I want to tell you about a clinical research that I'm about to start on developing electrophysiological biomarkers to help understand stroke and stroke management and rehabilitation. So why is it important? Medical advances have been great in prolonging life. So lifespan now, it's around 82 years, around 82 years today. That's great, we're living longer, but unfortunately, that hasn't necessarily translated to a longer healthy living. So lifespan, it's not the same as the disability-free living. That means that people are living longer, but are living longer with a disability. And if we look at the graph, it's the changed years in disability within the last 10 years or so. For people already under 30s, it's 100% change. And if you look into if we're living longer, then we're going to have more people living with a disability, which is quite harsh. And then that hasn't translated to healthy life expectancy. So we are living longer, but that just means that we're just carrying diseases as we live. So we know that aging is the risk factor that makes us having all these chronic conditions. And as Mary's participant, as participant Mary, that she had high blood pressure, and I can't remember what else, but she had multiple comorbidities. So the NHS has it very clearly on its website. There is a real demand for a healthcare service that is able to manage aging people, but it's a complex need because they don't only have diabetes, they may have diabetes, and they might have had a stroke, and they might have other chronic conditions. So for us to have a chance to help people and to meet the NHS demand, we need to develop tools, and we need to develop technological advance, like innovation, to be able to match this unmet need. So that led to my research on stroke. Stroke is the second cause for deaths worldwide, but it's one of the major causes for disability. So that means that there's people living just that have had a stroke. And when you have a stroke, you may recover, but you also may not recover. And that means that you're less likely to be able to use your hands. And what's even more concerning is that even if aging is a risk factor for stroke, we are seeing younger people having a stroke, which means that they're going to live longer with the consequences for stroke. So it just felt that something needed to happen. So my aim is to develop biomarkers based on how people move. And the aim, like the overarching aim, is first to understand the link between our central nervous system and the peripheral nervous system, not only during abnormal movements, but specifically on stroke. If this is successful, this will be a step change to the current management because it will be a tool that clinicians will be able to use. If you are a physio or if you work with a physio or if you've seen how rehabilitation happens, it is somehow subjective because all you see is if they're moving better or not. They're very busy, so they might put on a paper if the time to complete a task took 5 seconds shorter or longer, depending on the day. So if I develop these biomarkers, I'll be able to track disease progression and hopefully also develop a tool for prognosis. So that will help us manage expectations as well. How I'm going to do it, or how I'm proposing to do it, is to extract motor unit action potential trains. So every time that we move, just as we all have our own signature, our muscle fibers have their own signature. So if you're able to map that to the different stage of the rehabilitation journey, I should be able to understand where they're going to end. This proposed work is observational. So so this will allow us to also develop patient-centered approaches. So we are all different. We all have different needs. Everyone likes a different milk in their coffee. So why are we just generalizing health? Hopefully these will be able to allow for patient-centered approaches so that everyone is their own, or everyone has their own journey and everyone has their own rehabilitation goals. So why using EMG as a biomarker? EMG, by EMG, I mean electromyography, and that's kind of the voltage that is generated every time that we move. So by understanding electromyographic signals should lead to a better understanding of what's happening in our brain, because that is a translation of muscle control that translates to motor behavior. So we know that we are able to extract the signals from the muscle. From using algorithms, we are able to know the motor neurons and how they're firing, and whenever one is getting tired, the other one is jumping in. So we are able to know that. It's almost like reverse engineering. By knowing that, we should be able to understand the central nervous system mechanisms behind motor control. So I'm going to use a high-density EMG, just as we all want better resolution in our TVs. That has evolved as well with electromyography. So I'm going to use a high-density array, or a 2D array, where you can use, it's a non-invasive approach as well, so you don't cause any pain or any discomfort to anyone. It is based on a large number of arrays. It could be from 4 to 400 channels, depending on the system that you have. And essentially, you have multiple observational points, which, by the way, I brought an array if you want to have a look at it. Essentially, you have many different observational points, and by extracting algorithms, you are able to get physiological information about people. You're able to know if they're getting tired, if they're going to reach task failure, if they're shifting their moving pattern. So what kind of data can I get from high-density EMG? We can know motor neuron impulses, so when the synaptic input is happening, and we can know that in terms of the strength of the contraction, the type of the contraction. We also can know conduction velocity, so how quickly is the signal propagating, and this can tell us about the type of muscle fibers that are being activated. The two-dimensional maps allow us to see in real time and offline as well. This distribution of activity. So you also can have a region of interest, a region of activity. That's fine, you can carry on. A region of activity, and we can see if that shifts depending on if someone's getting tired or if someone's adjusting. And as I am assuming, people might not know what it looks like, I have a video of how it looks like. It's work that we did on violinists, obviously, and we were trying to see if by changing the chair, they would fatigue less because they are at risk of developing repetitive strain injury. SX and DX for the non-Italians, SX is left, DX is right. And you can see how every time that we move, it changes. So it's a very powerful tool. So the objectives of the members of this grant are mainly three. First, I'm going to collect all type of data that I can, demographic, experimental, and clinical. I'm going to be working with research nurses, both from Grampian and Tayside. And I want to know everything that I can from them to be able to make sense and to be able to put context to the data so that I can develop centralized or individualized approaches. And I'm going to track them, and I'm also going to record their movement, because with EMG, you know if a muscle is acting or not, but what you don't know if it's that movement is compensating for something else. So if someone cannot move their arm up correctly, they might adjust through the shoulders. And if you only look at the EMG, you'll see, oh yeah, it's activated. But if you have a camera, you're able to put context. Is it because they're trying to grab a glass that they couldn't otherwise? And I'm going to follow them during 6 months, and I'm going to record at 4 different time points, 0, 1.5, 3, and 6. I'm going to analyze that muscle movement. I'll extract the signal features. Hopefully, I'll be able to see the variations depending on the type, depending on the type of lesion that they had, where they had it, clinical measures like this service that they do normally. I am not going to change the standard of care. This is also an observational study. I'm just following and I'm just getting evidence from the signals. And the last objective is just to develop and validate these biomarkers. There are some biomarkers that have been developed with EEG data, with data from the brain. So I'm going to link them and use them to see if whatever we develop actually correlates. The intention is to use a Bayesian model with all the data in it. This is just how the array would look. The ARAT is the action research arm test. So this is just where the subject will be placed and how they're going to be grabbing or grasping things. As I said, I'm going to put cameras because I want to see the time they take to do a task, if they adjust, even if their posture is different, because that should also change as they recover. And that's just the arrays that I'm going to put on their arms, because I'm just going to focus on arms. So what research questions could be answered with the data acquired? Firstly, is there any effect on the recovery rate from both the, well, not both, from the three, from the clinical, experimental, and demographic data on recovery rate? We're going to be measuring spasticity and proprioception as well. So is that related to the movement dynamics and correlated to motor function? Are they more aware of their body? The better they seem to recover. Are there differences in the quality of movement and adjustment depending on their rehabilitation pathway or their improvement? Can we predict, ultimately, can we predict where they're going to go based on their movement? And that's kind of the big question. And if we are able to create those biomarkers, can we accelerate recovery by providing a feedback tool both to the patient and the clinician? So if successful, why? What will this help us do? Firstly, we'll be able to understand the link between the central nervous system and the peripheral nervous system. And not only will we be able to understand it, but we'll be able to put it context in terms of sex, in terms of type of lesion, site of lesion, weight, even including Scottish multiple index deprivation. We will be able to extract and identify distinct signal features specifically for each person, because like that's I didn't mention in my personal summary, but that's my bread and butter: individualized care, centralized approaches. So these will be able to help me develop that as well, which will allow for a tailored, personalized care, which is going to be benefit of a faster recovery rate as well. We'll be able to objectively estimate the motor recovery and understand how the muscle moves and how the control happens as a prognostic tool for functional recovery. It will not only help the person, but it will also help the carers and the NHS, just by providing a tool, hopefully, that will allow them to understand better if whatever intervention they are providing is actually meaningful or is actually helpful, and if not, just to change those things tailored to the goals of every participant. And these biomarkers, I am only talking about stroke, but I work with almost anything or everything that I can. So these biomarkers would have the advantage of being just applied laterally with motor neuron disease, Parkinson's. So I will also create, or I will put like open source database, so that not only I question the data, but everyone in the world can question the data as well. Yeah, and with this, we will be able to understand if rehabilitation is successful or not, and just quantify the interventions on stroke rehabilitation, which is something that is missing just now. So yeah, I'm sorry if I took too long. I'm sorry, thank you.